Welcome to another EMCT podcast on the topic of onboarding in emergency medicine. I'd like to welcome our guest, John Canion, NP, and we are going to have a fun discussion today about the evolution of the practice of NPs over time and where we are today in that. And I'm sure we'll come up with plenty of controversial topics and things, but we want to work through that. Welcome, John. Thank you for joining me in this podcast.
Of course, anytime.
Hey, cool. So you've been very vocal about the practice of NPs and all, and we're going to get into a lot of that discussion and how, in the end, we can assure patient safety. I want to just put a disclaimer at the front here that there will be some triggers probably that some people will find offensive at first, but just trust us in the end. We are advocates for patient safety and we're advocates for everyone's practice, but we want to just have a frank discussion and we'll talk about the elephant in the room when it comes to barriers potentially for patient safety. And our goal is to have wellness among all providers, and that means being confident in your practice and going home at the end of the day and feeling, hey, I've really done well for my patients, and I feel good about my profession, and not going home and thinking, oh my God, did I kill anybody? So that's kind of where we start the discussion, and we're gonna talk about some of those issues of patient care. But before we do that, John, tell me a bit about yourself and your background. What was your path to find your way into healthcare and all? And as an NP, I mean, just little snippet summary.
I was on my second sophomore year in college, on probably my fifth major, and I was actually hanging out with a girlfriend of mine at a cafe on a beach in California, and one of her friends from high school came up and he just happened to be there and talked to us about he was going to nursing school. And I was like, well, guys don't go to nursing school. It doesn't make any sense. I think I was in criminal justice major at the time. And I thought, well, I'm on my second sophomore year. I need to get out of school pretty quick. So he talked about make pretty good money and you can live anywhere, that kind of thing. And so I thought, well, whatever. I went back, looked at it. Sure enough, you could. So I went into nursing school. No, did not know the first thing about it. Didn't know anything, had no expectations or anything. And then I got into nursing, and liked the fast pace of the ER when I was in school, but I couldn't get into the ER because you needed experience. So I went and worked on the floor, and then I ended up in an ER and really enjoyed it. And then there were some PAs coming through who were training with the docs, and I felt like I knew the answers to all the questions that the docs were asking them. And at the time I was working as an agency nurse or locums nurse, and I was making more the only thing I could do to make more money very early in my career would be to go into administration. And I did not want to go into administration. So I decided to go to PA school. And somebody asked me, well, why don't you go to be an NP instead? And at the time, this was 2005. I didn't know what an NP was. And come to find out, there was only one in our town, population of 120,000 people. There was only one in our town.
What year is this?
2000, I guess it'd be 2002.
Okay.
So I applied to PA school and NP school, got into an NP school and got out in 2005 and immediately went to work in emergency medicine and been doing it ever since. I've done some urgent care and some hospice and a bunch of critical access stuff. So done a whole bunch of things in between.
So your first job was at what kind of a volume of an
20,000, 22,000.
And so you're an APP working alongside another physician. What kind
Yes.
of physician?
Well, so we had some, the majority of our guys were family trained who grandfathered into EM.
Mm-hmm.
And then we had a couple of board residency EM guys, but it was very, very small percentage. I would say less than 10% of our guys were EM residency trained.
And at that time, most emergency medicine trained and boarded physicians were going to higher volume facilities.
Oh yeah.
Yeah, clearly. Um, and that was a transition time. I think a lot of those emergency departments about that size are now a good percentage are emergency medicine board
Oh,
certified.
I'd say most of them are now for
And
sure. Yeah.
and the primary care physicians that worked in those environments made a career of it. It's not that they were
Yes.
working in the clinic and then,
No.
going there part-time or on, on call. They were actually full-time emergency medicine
Yeah.
physicians.
And most of them, I think, if I remember correctly, all of them, in fact, were boarded in EM, but they did the grandfather route.
That's a decent volume of patients to be able to get experience as well as a new provider. And I imagine there was quite the supervision as well. I mean, they would oversee your patients, I'm sure, early on, or you'd have discussions with them.
Well, for the first,
Oh, maybe not.
yeah, yeah, no, yeah, yeah. For the first 6 months, I had to see every patient who came into the ER,
Okay.
and I had to do every procedure that came into the ER, and I had to do, and so everybody that came in, I had to see, and yeah, and report back to them on every single patient for the first, I guess, 6 months, and after that, they gave me a little attitude, and then probably by the 10-month mark, I would just come to them when I had questions or I didn't know. So I'd say for the first 6 to 8 months, I was pretty much um, treated like I didn't know what I was doing. Which, I mean, to be fair, I mean, I had some training in emergency medicine when I went through school, but it was not. I mean, it wasn't extensive or as thorough as an EM resident or a resident trained, or even probably as much as the family guys did when they went through their residency. I don't know that for a fact, but it was my experience was more. I feel like I got more training on the job than anything, which was super helpful for my
Mhm.
career and for the patients that I take care of. So
Right.
it's kind of nice.
Yeah, and that's a great experience to have being an emergency nurse. And on that side of it, you can get lulled into, hey, I've seen all of these things. And then on the provider side, now you actually have to do the diagnosis. So, which pediatric fever are you going to work up and which are you not? Because that decision is made for you as a nurse. And when that table is turned, that's where I see APPs like, I don't know, and it's by patterns of behavior a lot of times because they're going, well, I don't know, Dr. A would do it this way and Dr. B would do it this way. How should I do it? And really, what it requires is evidence-based medicine. And that's not something you learn with on-the-job training, which has been the model. And unfortunately, patterns of behavior are tough to bring to the bedside and model for every patient. So,
Well, interesting.
yeah, how was that experience?
Well, it was it. I don't feel like I've had a rough time with that. Because the guys that I worked with were so diverse in the way that they did things
Sure.
that I had and of course they were very understanding and it was a good training experience through all the guys had different ways of doing things and different ways of or different ways of skinning the cat, as it were. But so I mean, I had to open Tentinelli's and had Tentinelli's on my desk and had to read everything, every shift, every patient. If I didn't know something, that I would stop and they would stop. Nope, you're not going back into the patient. You need to go look it up, go read it,
Awesome.
come back and teach me. So that's what I had to do.
Yeah, many are offended by that line, you don't know what you don't know, until they do learn it. And that's a tough pill to swallow, but there is no shortcut to being a good emergency provider or a good patient care provider in general. When you're tasked with being the independent provider for that patient, you have to be able to generate a good differential diagnosis and evaluate that patient fully and determine how best to care for them. And that includes even social determinants of health as well. How are they going to fill their prescription? So there's a lot to that to kind of put the bow on the package in order to prepare them to be well. And it again, there's no shortcut to that, and it requires a pretty disciplined approach. And that's great that you had attendings that cared enough about your education that they directed you toward an emergency medicine text or program that gave you that foundational training in addition to the clinical experience you're having contemporaneously. That's hugely important and something that I tried to do in bringing on our APPs years ago, because the tradition was always just on the job training, and you let out a little leash, a little leash, a little leash, and just
And hope.
and they don't hang themselves with it. And that's a big ask when you say, okay, well, when you have questions, just come and see me. And you're right, with the diversity of opinions on the different physicians that are supervising in a larger volume facility, there are some that are, would say, why are you even talking to me about this patient? And there are others that, are going to really nitpick and say, well, why did you do the CT scan? If
Right.
you knew the answer, that sort of thing. So that was one of the hardest things that in talking to our APPs about their onboarding is, what are your experiences? And it was the different opinions of the docs. And I said, look, utilize that as an advantage, that you get to work with many others and get to see it, many other opinions, because that's how you're going to form your practice individually. And you have
Yep.
to decide where you are in that spectrum of someone that is very cautious and you're going to order extra tests and know when to do that appropriately, or are you on that cavalier end? And then you got to be careful.
Minimalist.
So,
Yeah.
right, you're minimalist. So just you have to formulate where you feel comfortable in your practice and in your discussion with that patient. So, and again, there's no shortcut to that. And that isn't something you're doing as a nurse. And so you need to have appropriate volume and you need to have appropriate foundational knowledge and skills in order to go out and practice, particularly independently.
Yeah. And for patient safety issues too. I mean, it's, the old adage, you don't know what you don't know, is a really, people get frustrated hearing that. But if you don't understand the differentials and what the bad stuff is you're looking for, then you don't know to look for it. If you're not looking for it, you can miss it.
And you're right, knowing the red flags, knowing where the alligators are, that you want to try and avoid, you have to be able to have, again, a proper differential. And in emergency medicine, it's think the worst first. And
That's
then
right.
way back. So tell me about where you went then from this facility. At some point, you've worked in rural facilities as an independent practice provider. Let's talk a little bit about that. When did you feel comfortable enough to do that? And were you recruited to work in that environment, or did you seek it out?
I actually was recruited for it. I was working in an ER, and we had a group came in to replace us, the new management group came in to take over the contract, and they cut our salaries 40%. And I said, well, that's not going to happen. So, I mean, either you pay me what I'm in or I'm going to leave. And I ended up, I guess the day before they took over the contract, we were still negotiating. And then they decided they weren't going to negotiate anymore. And I said, well, you made this decision very easy for me. And I left. And so I started putting out my resume, and somebody that I had worked with before was working at a small critical access place and knew they needed help. And so they called me. And once they knew I was looking for something, and I went out there and interviewed and talked to them and got the expectations of the place. And I told them, I said, look, we're not going to be doing big, heavy traumas or anything like that. You guys have to have, EMS has to be on board with any kind of severe trauma at all. Just bypass us. Don't bring it here. We don't have the capacity to care for super sick patients. So if you can, fly them out. The population of the town's 800 people. It's just me and a nurse and an LVN and a tech. We're not, most of the time, most of the time you got that. Not all the time, but most of the time. So, you don't bring sick stuff here if you can avoid it. If it's super sick, go ahead and fly it out from the scene or bypass us and go onto the bigger facility. Have the support of the CEO and the supervising physician, who was going to be an ER doc that I knew. So I knew I could call him if I needed to. But again, if I'm stuck out in the middle of nowhere and I need to call him, the patient needs to be transferred.
Now, before you, well, when you guys lost your contract and you went to that critical access hospital, low volume, and we would call that a frontier critical access hospital. And in fact, if it was less than 2,500 patients a year, we'd call it extreme frontier, affectionately. How long had you been working as an NP at that time? And when you were going to go work independently, were there any other pitfalls that you could see, or were there any knowledge gaps or skills gaps that you felt like you had to fill before you went there?
Probably 8 to 10 years. The biggest thing for us is we had to cover the biggest thing for me was having to cover the inpatient side as well.
Mm-hmm.
That was the biggest thing. But in a critical access place, you're not keeping anything. You're not keeping anything that's sick anyway. Getting used to doing the inpatient side of things was the hardest part for me. The other hard part at that point, because I had only ever done handwritten notes. So they wanted me to dictate everything.
Ah.
So it took a little bit of getting used to dictation for a little while. Took a hot minute of rewinding and re-saying over and over again. I think my first dictation was the click, patient click, you know, because I'm
Well,
rewinding and
dragons come a long way. Yes.
yeah, it's
I,
significantly easier and better now.
yeah.
But then you had to get ready for the transcriptionist. So
Right.
pause, rewind, record, pause, rewind. Yeah.
Yeah, a partner of mine once intubated a patient, paralyzed him with socks on a clothesline.
Mm,
So,
mm,
yeah. So
that's funny.
yeah, it's come a long way. Initially dictation was actually by transcriptionists who
Yeah.
listened to it. That was a little different. That was nice. Going from that to Dragon was a painful period of time. I agree. And we refused it a number of times, went back to transcriptionists. So
Yeah.
no, I feel your pain. But you actually went a long time in the ER under supervision, clearly had
Oh yeah.
opportunities then to do procedures, intubations and chest tubes and see trauma patients and things. And by that point, 8 or 10 years, you've essentially done an APP postgraduate program, or what we had called
Well, I
the
mean,
residencies almost. Um,
yeah, not
in that,
not technically, but
right,
yeah. I mean,
right.
yeah. I mean,
But I
essentially.
mean, in that time, and we had had many providers that did that as well, and there were needs in the rural community, and they started then going from our facility, which at the time was seeing perhaps 50,000 patients a year, to facilities that were seeing 17, 18,000 patients a year, still as secondary coverage. And even from there, then they bridged out, after 10, 12 years or so, to some smaller critical access hospitals as solo providers, and then even had some telemedicine support so they could have some help. But at those smaller facilities, you're right, you're not keeping people. About 80% of admissions typically get transferred out. They aren't staying at those facilities, even if they would be admitted at a larger facility, to an
Yep.
inpatient unit. They had hospitalists. So you're right. The inpatient side there, it's your observation patients that are well enough. But you're right. That is as well the hardest part I felt was the inpatient side when I was at those. That responsibility is a bit foreign, particularly if they have an OB unit, and
Oh,
and then you're tasked with having to cover that until an OB comes, or their nurse midwife. So
that's
that's
my
even
least favorite thing. To knock on some wood here. It's my least
yeah.
favorite thing in the world. But
No kidding, no kidding. So let's talk about when things changed. In 2007, there was a change by CMS to recognize PAs and NPs as independent practitioners and reimburse for that service. Prior to that time, across the country, you had to have supervisory agreements. And this went legislatively state by state and led by state NP advocates through the state nursing associations and the board of nursing in all the states. legislatively got action state by state, and now roughly half the United States allow NP independent practice. But CMS, Center for Medicare and Medicaid Services, recognized PAs and NPs independent providers and reimbursed for their services without having physician oversight. Now, the argument was, well, what kind of oversight was there anyway? Because a lot of times this was just a paper document that said,
Right.
yeah, you can work under me, and it was still just let me know if you have any problems. And so in that sense, it probably made sense that why would you drag this physician into the liability of caring for patients that was getting taken care of by the solo practitioner anyway?
Without any input.
Right, without any input. And the other side of the argument is, no, you still need to have physician-led teams, and that's who should really be a decision maker. But if that physician isn't actively involved in the care of the patient, then are they really a supervising physician? Are they really going back and doing quality assurance, looking at charts and making sure that appropriate diagnoses were made, that sort of thing? The quality metrics that are looked at by CMS and elsewhere are, how long did the patient wait to see the provider? That sort of thing. All of these quality metrics that have nothing to do with, did the patient get good care? Did they get the right diagnosis? Did they get appropriate treatment? Did they get appropriate follow-up? Did they get the surgery they needed or whatever? None of those quality markers are looked at. It's all, whatever you can pull out of your electronic medical record that looks to see, did the patient have access? But is that really the most important thing? So I can see both sides of that. But in this time of independent practice, what did you see evolving as there are more and more NPs?
So essentially, I'm not sure how familiar we are with this, but the nurse practitioner role developed as an experienced nurse going back and getting a little bit more education, a little bit extra training so they can practice at a higher level, right? And the thought was that they needed 500 hours of training. They didn't need the full 2,000 because, like the PAs did, because there was a difference in, you've got somebody who already has medical knowledge and has seen patients and taken care of patients, so they can recognize sick versus not sick. So you only need 500 hours of training. And what's happened is, then I think 2010, the IOM report said that we needed more. There wasn't going to be enough physicians to take care of the ailing population. So we needed more nurse practitioners. So the nurse practitioners decided they were going to increase the number of schools. Well, you can only take so many experienced nurses out of the role before you have to start getting inexperienced people. And there was no change in the training. So you've got people who have no experience going through getting 500 hours of training, and then you're letting them go and expecting them to operate independently. Now, I think the quality of the education dropped off as we switched to online too, but that's a whole nother discussion. But I think what's happened is we've taken a model that was probably okay and switched it to a model which we don't know anything about without doing any actual studies on it to determine whether or not it's working. And then we've got independent practice, but nobody's done a true double-blinded study to see if it's working in states where we have independent practice. So, I mean, we're supposed to be an evidence-based profession, so we should be looking at the evidence. Well, my opinion, the evidence is not there. And I think we need more education, we need more training, and we need significantly more training. I think we need to go up to about 6,000 hours of training, is my opinion. And it needs to be a lot more, because I think if you look at the literature that's coming out there, the nurse practitioners who go through additional training, like a residency or a fellowship or whatever they want to call it, there's not a set term for us yet. Some call it a residency, some call it a fellowship, where they get additional year of training, whatever field it's in, family, ER, whatever it is. All of those people feel more prepared to practice when they're done, which they should be. If they've been working in that field for a year, you would think they would feel a little bit more for practice, versus the ones who don't do that, who come out and feel like they have, quote, imposter syndrome. That's what we're calling it from the academic side. And My question is it really imposter syndrome, or are we not training well enough? Well, I don't know. Our lawsuits are going up. The amount that we're paying out of lawsuits for nurse practitioners is going up. You know, all those things are going up, which is a negative to me. And we've got people coming out saying, I didn't feel prepared to practice. I'd cry myself to sleep at night. You know,
Right.
I don't know what I'm doing. And instead of looking at that and saying, oh, just shoo it off as that's imposter syndrome, it'll be fine. I wonder if we're actually preparing people appropriately, or if people are being successful in spite of their training instead of because of their training.
Right.
You
No,
know?
I've heard many, many tales and been the shoulder to cry on for many of our nurses that have gone out to these rural facilities right from their training. And, you know, they've done emergency nursing for a number of years and decided as an NP, all right, I got this. And the only jobs available were at low volume facilities, unfortunately, because the urban areas are saturated and there just aren't places for them to train and get the 8 to 10 or 12 years of experience, you know, that you had the advantage of having before you could go out and actually practice in that setting and be prepared for it. And it takes
Or
a long time.
residencies, you know,
Right.
time,
Right.
a couple of years actively
Yep.
training at
Right.
a facility. We're going to see tons of volume. You're going to get to do the procedures you need to do. So you have the confidence to be able to do them should you need to.
And I've spoke nationally about this, about the cart getting ahead of the horse. And it was at that time that there was this need. And you're right, the Institute of Medicine had put out lack of primary care, and this set up for venture capital companies to take over some of these NP training programs. And as the Bloomberg article that you're in referenced, I mean, it's become a mill, 100% acceptance rates, and let's just get people through. We aren't helping to arrange their rotations. You know, it isn't that you're doing spending some time in the emergency department, some time in surgery, some time, you know, with inpatient hospitalists, you know, some time with pediatrics. There is one of our NP students going through a program at my hospital who did her 600 hours in a well child clinic, because she could only find a pediatrician to help her get her 600 hours.
Right.
How on earth does that prepare you to go, okay, I'm going to go be an emergency provider now?
You
Um,
think that's bad? You
well,
think that's bad? I got one. I've got stories where people there's someone who practices who hires NPs or has NP students pay them, and they sign off their hours. And what they do is they come work in the clinic as nurses for them. He never trains them, and then signs off their hours at the end. It's been doing
oh,
it for a decade. Has about 3 to 5 NP students in his office at any given time, and has never ever seen had a faculty member show up at his office. And they pay him $2,500 a month each, and it's about 5 each all year long, every year. And he signs off a bunch of people, and there's no training.
I just find it crazy that the state nursing boards that have such strict guidelines for what RNs can do, what LPNs can do, you know, who can give IV meds and what meds, and who can give a baby aspirin to somebody, you know, is laid out so specifically on the nursing side. And, you know, even your nurse assistants, you know, everyone has very strict lanes that they have to stay in. And suddenly, when it comes to NPs, it seems the state nursing board's like, okay, you're good to go.
Well, there
And
is some of
I,
that, but there's 3 things that are supposed to dictate our scope of practice,
okay,
right? It's the population, so whatever type of NP you are, your education and training, right? So what had happened when I was in school was they said, we give you this best base amount of knowledge, and that's your part of your education. But as you progress through, you can get more education and training in other areas, but you need to keep that training and keep that education. So that way, if anything comes up, anything happens, you know, I'm gonna knock on some wood over here. It anything happens, you can prove that you've been trained in these areas, right? So for instance, whenever I was doing my training, we had anesthesia gave us an airway course, so I kept that. and we were supposed to keep that stuff for 5 years or whatever. So I would keep that stuff. So I would have it. And that was part of our way of proving that we have at least done this in the past. And we've had some education and training on it. So that way we can go, if anything happens, complaint to the board, or God forbid, I'm knock on wood, something bad, we can prove that we've been trained to do that. So that's part of what it was. Now, what's happened now is the academics are saying, no, you need academic training in order to do that, right? That's what they're saying now. If they're trying to get more people into schools, so you can get an acute care or an ENP or whatever, which is fine, and from a education training perspective, if I'm hiring someone now, I'm looking for that more, because at least I know if you've got an emergency nurse practitioner, at least I know you've been in an ER and you've at least had some education on emergency medicine. It may not be extensive, but at least you've got some, because there was a paper that came out, say 6-8 months ago, which showed the wide variation in even emergency programs.
Right.
So there's not standardization, which is another issue. I got a whole bunch of issues, but and big old soapbox. I can go on for hours, but yeah, there's no standardization. So you can't, academics don't control clinical education. There's no standardization of training. So when you get out, you're looking at somebody. And so what's happened in the past was, let's say you're the medical director. I'm working with you. You're like, hey, John's really, really good. We like him a lot. He can go see all these patients. He's very good at what he does. He can do all these procedures for us. He can operate really well for us. We really like him. Well, John's an F&P. So Jimmy Bob's an F&P too. So he has the same credentials. So he should be able to do the same thing. And
Right.
you would think that, but it's not true, because I've had additional education and training where Jimmy Bob didn't. And that's the issue. And when it comes to credentialing and insurance panels and all that, trying to sort out the difference between us is just an absolute nightmare. And then you get people who come in who don't want to do. They go get their NP, and they don't want the decision-making process. They don't want to do that. They don't want to do that. They just want to be an NP to be an NP, whatever that means. I don't even know, but that's what they tell me. And one of my colleagues calls them RN pluses instead of NPs, where they can write prescriptions and they can do all that, but the decision making or anything difficult they shouldn't be doing. And I mean, I don't know. There's such a wide variability in our training, such a wide variability in everything, that we're not as plug and play.
Right.
You can't really do that. And if you get an emergency medicine trained ER doc, you know what you get. If you get a family practice physician, you know what you're getting. You know what the training is. If you get a trauma surgeon, you know what the training is. You get a vascular surgeon, you know what the training is. You know what they should be able to do and not do. If you get an NP, well,
Right. And that's the issue, though. And it really comes down to two things. When we talk about an NP going to work in a rural setting in an emergency department as an independent or solo practitioner. And one is they have to have the desire to go there and feel that they're prepared. So the onus is left on them. There are no guardrails put up by the state nursing board, by any government service, by any state agency, again, federally or state or local. And then it comes down to the individual hospital and what those credentialing criteria are. And we did a survey, the American College of Emergency Physicians Rural Task Force in 2019 did a survey, published a report in 2020, using a large listserv sent out to APPs across the country, and asked them what your credentialing criteria were. And the vast majority said, hey, all we needed to do was have ACLS, ATLS, and PALS, along with our NP or PA certification, and we were allowed to work independently. And obviously that's woefully inadequate, but some took that as proper certification. That's, hey, I'm prepared to go work because someone's given me those credentials. I must be prepared. And that brings us circling back to you don't know what you don't know. And a lot of these providers, they want to get handcuffs on them because they don't want them to leave after they've done whatever onboarding they do. They need coverage. And so then they give them incentives to stay for 2 years. And in 2 years and a day, they leave because because they realize, oh my God, I've dodged a bullet so many times, or they'll leave before that and like, I don't care, about any signing bonus you gave or loan repayment or anything. I've got to get out of here, because they've had a bad outcome in that setting, and it's inevitable.
Yeah, I think the training is the big issue. So, and the other problem is, again, they go back. The hospitals don't know. They just see requirements online. They Google it, and somebody's got ATLS pals and ACLS. They should be able to do it, and they're an NP, or they happen again to have somebody who out there who's good at what they do and has those credentials. So they figure they can use somebody else with the same credentials. And unfortunately, the reality is they don't understand that the credential behind the name doesn't necessarily mean what they can and can't do. And just because somebody says, "Yeah, I'm sure I can do that," doesn't mean that they've had appropriate training for it either. And we get into these situations where you get somebody out there who doesn't know, and then you get people with tendon ruptures that aren't repaired or aren't sent to the right people. You get people who can't intubate, can't crike, can't put in a chest tube, don't know. I mean, the list goes on, but we're setting up for a dangerous situation. The only plus side is the volumes are typically so low that if you have something come in, that's
Right.
generally your only patient till you get it done. So, I mean, that's the plus side to
Right.
that but the downside is without the training, you might not realize it's a bad patient. So
Right.
I think it's, I mean, there has to, the rubber has to meet the road somewhere. So we have to fix something, because this is going to, I mean, it get worse before it gets better. Like, I mean, my dad got 2 misses and could have been a very, very, very negative outcome. And
Mhm.
it's something where, and it was basic stuff that they should know.
Right.
But
Right.
it's I think the training's just not there. And it's hard to say. And the problem is who has the training and who doesn't. And how do you determine that? That's the real issue. When you're getting, and you got to get people, they need coverage, but we also need people who are competent to give that coverage and competent to be able to take care of people out in the critical access in the rural areas. Because I went out there, worked 5 years, tried to get my student loans prepaid in a critical access town of 800 people, and couldn't get a penny of my loans repaid, which is why I went back to the bigger cities that paid better.
Right.
So and I liked working in the critical access area. It was nice. It was fun. But it's, and then I go back and go from doing everything, go back to a regular, a different hospital where they just want me to do fast track only, you know?
Right. Right. Right.
So, and that's the other thing. So you get an NP who has on their resume, I've worked in an ER for the last 10 years, but if they've only ever done PIT or fast track,
Right.
does that, I mean, is that somebody you want to,
Yeah. Well,
woo.
let's start talking about solutions, because clearly we've laid out the reason why the training is needed, and we need to drive change by calling out some of those problems with the current system. So we really need to point out all of these shortcomings in order to drive change. And the way a lot of that has been generated now is by looking at, hey, look at all these bad outcomes. And News Nation did a piece on this, Bloomberg, and they want to identify what are these bad cases, and then they kind of just leave it because there isn't a solution, like do something. And that's why we're meeting today, because I think there truly is a path forward, and there are people trying to figure it out. But let's look at and here, I'm here with you. I'm here. So um, let's talk about what those paths forward are. And just to preempt this, we had this discussion. ACEP did commission a rural task force in 2019, published in 2020, and came up with some criteria that we felt were minimum criteria to prepare an APP to work independently at a rural facility. And those criteria were: one, to have foundational training. So what you're talking about with reading literature and getting some training, understanding pathophysiology and treatment, how that's directed at treatment of disease is key, because you don't want to just do pattern-based or behavioral
Sure.
kind of
Sure.
care. Second was, we recognize, where are you going to get in trouble? What's going to kill the patient first? Airway. You need to have specific airway training. So that was second. Third was team-based, because you've got a team that you work with. And there are courses that do that. The CALS course, Comprehensive Advanced Life Support, is a course in the Midwest that teaches team-based learning. The ACS, American College of Surgeons Rural Trauma course, does that. The fourth thing was the biggest obstacle, and that's the traditional approach. It's time spent at a high volume facility. How do these critical access hospitals afford to staff their emergency department and have someone in training paying for them at another facility for 2 years or 18 months if they're going through a traditional postgraduate program or APP residency, so to speak? How do they afford to pay for two providers at the same time? And that's where then everything falls apart. So let's not do anything.
Yeah.
But that's necessary. The fifth thing was that you needed to have telemedicine support, tele-EM support, with board certified emergency physicians available to help you in those times. And then whatever that oversight is, do you see every patient? Seems unrealistic, but that's what some people call for. Or do you just see them selectively? And then the other is to have, we did an extension beyond that of EM medical directorship, a physician-led team, that can assure that these providers are prepared to work in that environment, and that,
Sure.
quality assurance and that sort of thing. So those were the minimum requirements. Now, again, a postgraduate program in emergency medicine can accomplish all of that.
With enough training hours.
Right, with enough training hours. Yeah, if you're doing that full time in a postgraduate program, unlike your NP program, which, hey, I was working full time as a nurse, raising my family, and between 9 o'clock and 11 o'clock in the evening, I'd just hop online and knock out a few modules and and write
If
a few
that.
papers and learn
Yeah.
about
Nothing.
yeah, nothing.
Nothing. Yeah. Nothing.
Okay,
Yeah.
you said it, not me.
Yeah. Yeah. I'm well aware of yeah, I did work as an assistant professor for a little while too. So I'm well aware of
All right,
the
academic
issues
rigor.
there. But yeah, I mean, not necessarily not learning anything, but the mechanism is not set up to be difficult and challenging.
Right.
And it should be. But yeah, I don't know. I mean, that definitely is helpful. I've heard of the telemed ER backup. I've never seen it. I've never worked with it. The times that the places that I know of that do that do it, they anytime there's a code or a trauma, it activates. And then if the person who's on shift has a question, then they can call into the center and get the tele support. Those are the the indicators that I know of off of the place that I know that does that. Now, in defense, I only know of 2 or 3 places that do that, so this is not extensive or wide for the tele support. Every place I've ever worked, I've not had a place that actually has that as an option even. So I don't know. I don't know how much I
That's
would
the
use it,
point.
but
Yeah, right. And well, I can tell you, when I work at some places, it is there. I've never used it myself, but under the Mayo system, they've actually got someone that's watching particular hospitals. And I happen to be at a low volume critical access hospital where they normally staff with APPs. But to the Mayo's credit, when they don't have an APP to work there, or they are in training, they send physicians there. And here I am, board certified emergency medicine. I'm working at a 3,000 volume ED, just filling in an occasional 24-hour shift.
yeah. Yeah.
Which, it can be really nice, but you'd be surprised how you can be duck bit around the clock in 24 hours.
Yeah.
People coming in, and it's like, oh my God, that was a kind of tough shift.
Yeah, I went to a place where they averaged about 6 a day, and I did a 60-hour shift, and I saw 58 and transferred 18. And the
Right,
nurses were
right.
like, "You're a black cloud." I'm like, "It's not me."
Right, right. Well, I know. And then there are other times that it's great. But
Yep.
my point is they will cover and make sure that you have qualified providers there. And if their APPs are not ready, that's where they would send us. So there are systems that actually will oversee departments. So they'll have 7 screens pulled up from the various EDs and be overseeing them. And there are different models. There are others where it's just a red button you hit and it's like, I need help now.
Yeah.
You're in crisis mode potentially in some patients, or if you just have a question. So there's different models for teleemergency medicine, and that's a different podcast that we do on a couple of models. But it's a good system, but it too needs clarity on what those guardrails are. And it's different if you're new to the facility or if you've been out for 10 years. And the same thing is true if I were working alongside of you in a 70,000 volume ED. Let's not pretend that I'm seeing all of your patients
No. Yeah.
just because you're there.
Right.
These providers still come to me when they have questions. Now, should I be assigned to that patient that you're seeing and at least be aware of them? Absolutely. And I do look at my whole list of patients when I'm working with APPs, and I can recognize red flags and chief complaints, and I may just say, hey, John, what's going on with that guy with belly pain and fever?
Yeah.
What are you thinking with him? And I can see what you've ordered, but if it's flank pain and I see you've ordered a CT scan and I see the stone and a clean urine and no fever, and you've got plans to have him follow up with urology, I'm not gonna do anything more with that. I'm not going to see the patient typically.
Right.
And I would get a lot of criticism from colleagues that that's not appropriate, that you should be seeing every patient. And
Yeah.
I think
I
that's
think it's
different in different practices and
well,
different.
it's unrealistic too. I mean, if you and I are working and we're both busy, it's very difficult to see my patients and your patients at the same time. And to expect somebody to be able to do that is just unrealistic unless you don't have a patient load. If you don't have a patient load, then it would be possible. But if you're seeing your own patients, you get a critical patient come in, you get stuck in a procedure, you're in there for an hour. I've discharged 5, 6 people. I mean, it's unrealistic to assume that's going to happen unless you're in a position where you're just supervising and not seeing patients. But I've never worked in an ER where that's even a viable option, much less something that anybody could do if they wanted to, because there's too many patients, and we all try and every group tries to run their departments as thin as possible. They're trying to cut hours and save money and send people home and all that stuff. Where if we're doing that and suddenly it gets busy, you've got a code, I've got a code, whatever, and
Right.
then next thing you know, 10, 15 patients later, an hour later, you're caught up and I've discharged 10 people who've come in. There's no way. I mean, it's just not viable. Or you work in a situation where you want to see everybody. Well, then I've got 10, 15 people holding to be discharged so you can run down there and poke your head in on them. It's just, it clogs up the department, messes our throughputs up, gets all our metrics out of whack. And then it's the CEO down there, I mean, you get all kinds of other problems in this. I just don't see it as realistic. And on the low hanging fruit, it's probably not as big a deal, right?
Yeah.
The low hanging fruit stuff, it's probably not as big a deal. I mean, but the places, I like to work at places where I'm a little more independent and can see sick patients and take care of stuff. And do I like having hell yeah, I like having my docs there so they can back me up in the larger facilities. But if I'm in a little bitty facility and I'm not hesitant to pick up the phone and call the
Sure.
big facility down the road and be
Sure.
like, hey, I got this guy, he's coming to you. I mean, I had my first fastest transfer was 8 minutes, from the
Sure.
time they arrived till the time I had transport secured. Cause I knew as soon as the patient was coming in, they're not staying here,
Right.
I mean, it's not, all I need to do is make sure that you're stable enough to get there. That's my job.
So swinging back to the path forward for training, there are organizations that are looking at this, AAENP for NPs, SEMPA for PAs. it's not an area that emergency physicians have looked to be a leader for APPs. It's very controversial, unfortunately, to even consider APP independent practice. I don't see it going away. I
No,
don't see it based on workforce that we could ever create enough emergency physicians to work in all rural emergency departments. And that's the type of departments you're alluding to are those facilities that it'd be tough to justify. So what's the answer? Yeah, and it does come down to the money and and what do you do uh, to get that? And that's where I recently had a discussion with someone from representing the Center for Medicaid and Medicaid Services, and there's a condition of participation for these critical access hospitals that they need to have emergency um, providers there 24/7. And it goes on to say that those providers need to be emergency trained. And then it stops. When it says you need to have a proper emergency equipment, it lists every bit of equipment that you
yeah,
have to have, you know. Uh, and I make the joke it's down to the urinary catheter because it is. I mean,
yeah,
literally the urinary catheters you have to have it, in addition to all your resuscitative equipment and all. So when it comes to equipment, yes, very detailed. When it comes to training, it leaves it blank. And the question is, does that need to be revised? And if so, who's going to pay for that additional training? And my contention is it just needs to go into the global budget of those critical access hospitals and get folded in. And that needs to get approved through CMS for their global budgets so that they can assure patient safety and allow these providers to practice competently and, as importantly, confidently for wellness, sustainability, and have proper oversight. And again, that comes down to tele-EM. And this does allow emergency physicians to have a tremendous impact in these rural communities, but still be able to live where they desire, which is in the urban setting, and be able to work at their higher volume EDs, which they were trained for.
and what they most of them enjoy doing. And
Right.
the flip side of that is you can get somebody who is a nurse practitioner or a PA who's been trained enough that they can do this, go out in these areas and they can work less days.
Yeah.
So they don't have to work 15, 17 shifts a month. They can work 9 or 10, and do 24s instead and have a better lifestyle.
Right.
So, and then they don't have to live out there either. They can live in the urban center, go out, work their 10 shifts a month, and then come back or whatever it is. And it's a lifestyle boon for them, and it allows them to, still work in the bigger center if they want to on the side or do whatever else they want to do. I think independent practice is inevitable. I think at
Yeah.
this point in time, it's inevitable. But I think what we need to do as uh, professions is come together and say, hey, look, we know this is going to happen. We understand that. We don't feel like, and for me, from y'all's perspective, I would say we don't feel like the nurse practitioners are trained enough to practice independently upon graduation. I, as a nurse practitioner, would agree with that 100%. A lot of my colleagues wouldn't, but that's fine. If we could come together and say, and ASAP, well, if that could get in the room with those guys, we could say, look, this is what we need to do. This is the criteria we need to have for nurse practitioners to work in the emergency department, period. And a lot of EM groups are starting to require emergency certification from the nurse practitioner side, emergency certification from the PA side, which is a good thing. The problem is the training is not standardized. So
Right.
if we were to come together, like get together with ASEP and say, look, this is what they have to know to work in these settings. If we are going to support you, you have to have X number of intubations. You have to have seen X number of deliveries are partaken in. You have to have seen X number of chest tubes. You have to have seen whatever. Then we can come back to the nurse practitioner programs and say, look, this is what we need you to get these guys to do for us to feel comfortable with you being there if my family member came by and had a problem.
Right.
which is
Well,
at the end of the day, what we need to do is be comfortable with uh, my family member getting taken care of.
and from our perspective, and I'll give it from the physician side, we're advocating for physician-led teams.
Mm-hmm.
And and I really see that as appropriate, but I think it falls short if we say we're going to be a physician-led team and we aren't going to be a physician-led educational program. Now, AANP and SEMPA are looking at those criteria, but again, personally, I think emergency physicians trained in this profession really should be at the table to help you to make those decisions. I mean, as much experience as you have, John, I mean, you certainly are valuable to point out clearly what you need to get there. But I still think that emergency physicians have that broader training and experience that says, yeah,
Sure.
but we need to have this, and you're going to be working with us. You know, we want to have this telemedicine support. This is what you can expect, you know, when you talk with us. I think we should really be at the table and be part of that, and that still is evolving, and the
100%.
relationship is evolving, and hopefully we get some clarity someday, and you know, the skies open up and we go, ah, okay, now I see
The
the
other thing I'd say though is I would say that not just for rural setting, I would say I would
right,
want them to be all of them to be for every emergency
right.
setting. Because I mean, I've worked in a place where it's you and one doc, and if the doc goes down while you're on shift,
Or they're distracted with a procedure, and it could be
or multiple codes come in at the same time, something like
sure,
that. I mean,
sure,
there's all kinds of situations I've been in where if I hadn't had additional training and hadn't had additional time spent teaching me that stuff, it would have been a very bad situation. At the end of the day, we need to make sure that we're comfortable seeing the patients and we're trained competently to take care of the patients. So um, you can be comfortable that I know how to care for the patient should something happen. And I would argue that it not just for critical access, but for everybody working in the ER, there needs to be a set of criteria, a set of training that needs to be bar minimum to get in. And what the downside of that is, you would have a barrier to entry to practice. But the upside is, if I've completed that training, you would know as a medical director and as a credentialing body part of the hospital what I could do and not do, versus relying on me saying, yeah, I can do that, you know?
right, right. So hopefully we get to that point. Right now, I think patients are still vulnerable, because there is that ability for under-trained PAs and NPs to be seeing patients without proper supervision. And you're right, it may be even in high volume facilities where the physicians aren't engaged in the patients you're seeing, and you're leaving it up to the APP to go when they have questions, but they aren't going to have questions on something they don't know about. So they may send somebody out entirely missing. You're right, an
Yep.
ischemic bowel or whatever, you know,
Yeah.
whatever else there is that they hadn't seen before. So those are still risks, and hopefully we can come together with some minimum criteria for APPs to work in any department,
Yeah, and
and
some way to
hopefully,
train people, and some
yeah,
way to train people, and especially for those that are already out in practice. I mean, for those who are already in practice, who it would be unrealistic to send them back to an 18-month residency, some way for them to jump through the hoops and get additional training. And there's a lot of us, like I went and got the emergency certification. I went and I grandfathered in for the test. And then I'll tell you that I did not have a difficult time with the exam at all. So I mean, and my friends at the AANP get mad at me when I say that, and it's not. And instead of saying, "Hey, why do you think that?" they just get mad at me. You know,
right.
we should have been more difficult. We should have been a little bit more um, difficult in the way we asked our questions. But the other thing we have to realize is the NP exams are generally entry to practice exam, not mastery exams. And that's a completely different way to test people. It's
Yeah.
entry to practice is we don't think you're going to harm anybody if you've passed this test, versus an expert exam where we're testing your expertise versus we're testing what we think you probably not going to hurt anybody.
Yeah. Well, and who should be judging, I guess, when you're prepared to go to those rural facilities and those health systems and organizations that are engaged? And we pointed out at the Rural Task Force, the Mayo system, as a best practice model, that they actually have their emergency physicians and their program decide what your time spent at the large volume facility needs to be. And that may be different. If you've got a lot of experience in other emergency departments already, and you come to this emergency department with that wealth of experience, then your time might be 6 months. And you
Right.
might be prepared to go, once they've put you through proper airway training and other procedural skills, and you've spent time with those docs and get to know them, the docs that are going to be your tele-EM support, they decide. And I think personally that's the way it should be. You can't guarantee that you're going to have an NP at that facility that can properly assess you as to when you're prepared, or a PA. And you can't have some central body like the AAEMP say, okay, you're ready through this health system in central Iowa to go work independently just because you passed an exam and you've checked a few boxes. It really needs to be local physician-led teams, and there need to be criteria in place that say that this is the standard. And then it comes around to what is the funding for that. And that's always where
The
things
rubber meets
fall
the road.
short. Yeah, things fall short, and there needs to be a mechanism for that as well. And hopefully CMS will look at this and the condition of participation and somehow be able to fold this educational funding into a global budget for these critical access hospitals particularly. But that mandate will come forward for larger facilities as well. And so everyone will have to deal with that. So,
Yeah, and I think I just think that the education is the biggest component,
yeah,
and if you give people who are educated and trained, then you'll get people who can at least can function at a base level. And the question is, what is the base level, right?
right.
That's the thing we got to sort out, and we got to sort out how to train them. What's the best mechanism of training? And unfortunately, there's just no literature on that at all. There's no literature on what training is required from an NP to get from a base NP to being able to practice at a critical access and safely. What the flip side of that is, there's none saying they can't do it now.
Right.
So
And in the end, again, as we kind of led with this podcast, our goal is one, patient safety, but two, we want these providers to have wellness and
yeah,
to be confident in their
oh yeah,
practice and feel good about their practice. And there's no feeling good about being questionable or having this inner dialogue with yourself after your shift, reviewing all the patients you saw. Why didn't I LP that kid? you know,
it's definitely an interesting topic, and it needs to be addressed. And the problem is nobody really wants to address it, right? I don't know much about what SIMPA's doing with the AENP's kind of addressing it, but not really. ACEP's kind of like, I don't want to touch that, for their own reasons. And I think that, I mean, honestly, the y'all's profession, our profession, need to be on board on getting this fixed, because I do think it's inevitable, the independent practice thing. Even if you do a physician led team, I think it doesn't matter. It'll still be by legal requirements, independent practice or whatever. But I think that you having people who are trained appropriately, either way, it's the training still needs to come. No matter how that ends up, and training needs to come. And if you have both professions agreeing that, hey, we need training, it needs to be standardized, we need to know what we need to know to go out and be successful in any emergency department, and to be able to help in any emergency department no matter what comes up, that helps. And then also, how do you utilize your NPs if you're in a big facility? I mean, if you only ever put them in fast track, that's all they're ever going to be able to do. So, you just how you utilize people helps. But, I mean, you got to have people who are willing to do more than that too, because there's some of us that don't want to do any more than that.
Right.
So, I mean,
Yeah.
and do those people really need to be in the ER?
So where we are now, it's voluntary essentially for hospitals or health systems or physician groups to set up a minimum standard of training or to lay out an onboarding program for working in emergency medicine. And more are recognizing the need for that because they're all getting new graduates. At least some of them are new, some are mobile and go from one place to another, but it's very inconsistent. PA training, very different from NP training. So you have to be unique in your approach in your onboarding, but at the same time have consistency. So it's difficult when you have people come from different backgrounds.
Yep.
And that voluntary approach means that you're going to have a lot of people just reinventing the wheel, some doing it very meticulously and rigorously, others doing it a little less so. Where I see the change going is from the health systems, one, recognizing this and setting up these programs, and there are different points and different health systems they looked at, and physician management groups, some call them CMGs or the contract management groups, or other independent physician groups or smaller groups that have contracts at these emergency departments are doing it internally. And everyone is kind of figuring this out on the fly on their own, that they aren't getting emergency medicine trained providers, that NPs and PAs are not prepared to see patients on day one, and all recognizing that they need some kind of onboarding training, and that they come with different skill sets.
Yep.
So many are looking for foundational training, and that's why we've created our program, Emergency Medicine Core Training, for that purpose. But others are recognizing that they need to spend time, doing a CALS course and spending time in the OR doing intubations, because oftentimes the emergency department is not the place to train in intubations if they're going to be going and working independently, and really have some oversight and being able to track their progress as they go through this training program, and then do an assessment along the way as to when they're ready to launch. And that's part of a physician-led team, and leading to appropriate utilization of APPs at high and low volume facilities. And hopefully we get some clarity on that, and some buy-in from not only AAENP and SEMPA, but hopefully we get everyone at the table. And ACEP is doing a good job with that as well, trying to reach out to these organizations. But again, it's advocacy organization for emergency physicians, and it becomes
Right.
a very political and contentious issue at times. And those conversations have started and stopped many times. And hopefully we come to some conclusion, where we all work together and do the best for our patients broadly in the field of emergency medicine. Well,
I need
good.
to look at your program too, by the way. Need to get a look at it. See.
I will get you access.
All right, you're awesome. All right.
Sounds good. Hey, thanks for joining us in this podcast today, John. I think we've covered a lot of ground and really pointed out the necessity of proper onboarding and training in emergency medicine, and how we can have a sustainable path forward for these providers, for patient safety and for our providers' sake.
Yeah, sounds good.
Thank you, John.
Of course.
Yep. Take care now. Bye.
Bye. See ya.